This presentation is provided to discuss the indications, mechanisms of action, and other relative information regarding the use of precedex in anesthesia practice. Precedex has anxiolytic, sedative, and hypnotic properties. It is a relatively selective alpha-2 adrenergic agonist and acts by activating an inhibitory G-protein coupled receptor. In the central nervous system, it can act both pre- and postsynaptically to hyperpolarize the neurons, mainly by promoting potassium efflux, which in turn inhibits excitatory neurotransmitter release and thus results in sedation. This schematic shows precedex binding to GI protein receptor, causing potassium efflux and resulting in cell hyperpolarization. In the vascular smooth muscle, the activation of a GI protein-coupled receptor leads to vasoconstriction through the inhibition of adenylyl cyclase that leads to decreased cyclic AMP production. If cyclic AMP is not present, then it cannot bind to the myosin light chain kinase that is then free to form a myosin light chain kinase calcium calmodulin complex that will then act to vasoconstrict. But please note, this is a transient response. This schematic again shows precedex binding a GI receptor, inhibiting adenylyl cyclase, and therefore inhibiting the conversion of ATP to cyclic AMP. Precedex is supplied in a 2 ml single-use clear vial at a concentration of 100 micrograms per milliliter. Before use, it should be diluted with 48 milliliters of 9% sodium chloride, for a final concentration of 4 micrograms per milliliter. Precedex is administered intravenously with a controlled infusion device. The induction dose of precedex is 1 microgram per kilogram over 10 minutes, followed by a maintenance infusion of 0.2 to 0.7 micrograms per kilogram per hour. It is not recommended as a sole induction agent, but rather as an adjunct. For an awake fiber optic intubation, an infusion of the upper range limit is recommended until the endotracheal tube is secured. Precedex can also be used for sedation in the intensive care unit or for various procedures. The induction dose should be followed by a maintenance infusion that is titrated to clinical effect, up to a maximum dose of 1 microgram per kilogram per hour. Evaluation of clinical effect should be within 15 to 25 minutes after the initiation of the infusion, and then every 20 to 30 minutes. The onset of precedex when given with a loading infusion is 5 to 8 minutes, but may take longer if no loading dose is given. Peak effects are seen within 10 to 20 minutes. This graph shows that a loading dose of 1 microgram per kilogram followed by a 0.3 microgram per kilogram per hour infusion produced more pronounced sedation quicker than the lower loading dose of 0.5 micrograms per kilogram and a decreased infusion of 0.2 micrograms per kilogram per hour. Both precedex infusions produce more sedation than a placebo effect shown in green. The distribution half-life, or T1/2 alpha, for precedex is 2 to 4 hours, and the elimination half-life, or T1/2 beta, is 2 to 5 hours. Precedex is 94% protein-bound and undergoes almost complete biotransformation via glucuronidation and cytochrome P450 metabolism in the liver. Very little drug is excreted unchanged in the urine and feces. Hepatic impairment will therefore lower the drug clearance values. Gender, renal impairment, and age did not impact the pharmacokinetics of this drug. However, you should consider a decreased dose if given to the elderly. The pharmacokinetic profile in children has not been studied. Anesthetic indications for precedex are as an anesthesia adjunct to achieve sedation and analgesia. It can theoretically be used as a sole induction agent, but again, this is not recommended. The claim to fame of precedex is that there is no evidence of respiratory depression when an IV infusion is maintained within the recommended range. Precedex will enhance other anesthetics, sedatives, hypnotics, and opioids, so a reduction in the dose of precedex may be required when using these agents. There are no absolute contraindications to the use of precedex. Animal studies have, however, shown that it may cause fetal harm and should therefore be avoided in pregnancy. Caution should also be exercised when administering to nursing mothers. The most common side effects of precedex are hypotension, bradycardia, and dry mouth. Bradycardia and sinus arrest have occurred in young healthy volunteers with a high vagal tone or when administered as a rapid intravenous or bolus dose. Hypotension and bradycardia may be more pronounced in patients with hypovolemia, diabetes mellitus, chronic hypertension, and in the elderly. Co-administration with other vasodilators or negative chronotropic agents should be done with caution due to the additive pharmacodynamic effects. Caution should also be used in patients with advanced heart block or severe ventricular dysfunction. Transient hypertension was observed primarily during the loading dose, so consider a reduction in the infusion rate. Prolonged exposure over 24 hours is not recommended as it may be associated with tolerance and tachyphylaxis, and a dose-related increase in adverse events such as acute respiratory distress syndrome, respiratory failure, and agitation. Continuous monitoring of blood pressure, heart rate, and oxygen levels should be done during infusion of precedex. Symptoms that may occur within 48 hours after the administration of precedex include nervousness, agitation, headaches, weakness, confusion, excessive sweating, weight loss, abdominal pain, salt cravings, diarrhea, constipation, dizziness, and lightheadedness. In summary, precedex augments other sedative agents, thus reducing the dose of other agents while minimizing respiratory depression and allowing the maintenance of spontaneous breathing. Precedex is therefore recommended for patients over 65 years of age and for awake fiber optic intubations. Precedex helps avoid oversedation and promotes communication during the procedure. Precedex also helps avoid delirium in susceptible individuals. These are the references for this presentation. Thank you.